Good morning, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and as always, joined by our Medical Director, Dr. Kim Pruitt.
Hey, Chief.
Welcome, Doc. And today, joined by soon-to-be Captain Ryan Irizarry from Station 18.
Thank you, sir. Good to be here.
Thanks. It's good to have you here, and thanks for joining us to talk about an interesting case that we don't necessarily get to see very often that you and your crew handled really well. And it's a case around pulmonary hypertension. So you assigned to Rescue 18 currently, and you guys were dispatched to a 21 Charlie. So you kind of talked about not a lot of information came through on this call initially. So talking through what you're thinking about when you're en route to this call for a 21.
The short of it, I believe the coding for the 21 was hemorrhage. So we're trying to kind of think of what differential diagnosis, what kind of hemorrhages could we be faced with. Oftentimes when it comes to 21s, I associate GI bleeds or something of that nature, or it could be something as detrimental as some sort of laceration or something. But on the way to the call, simply stated, it's just like it's a hemorrhage. They're going to be bleeding somewhere. We're going to be falling back on BLS. The whole simple things before we move into whatever else. And I think we definitely got thrown a curveball on this one. So, yeah.
It sounds like. So when you arrived, the dispatch was for a 73-year-old female. You arrived at her house and learned very early on in your assessment that she had a history of pulmonary artery hypertension and had a medication pump that had become dislodged. So talk us through what you saw when you got there.
So when we arrived on scene, I remember the family was there. They were really concerned based on this pump, and the concern was the fact that the pump wasn't plugged in or running. They explained to me the pulmonary hypertension condition, which we have a little vague familiarity on what that condition is, but the medication that they explained to me that she has to be on this medication, that was the big emphasis. When we got into the house, and they're explaining to me from the truck into the front door, we got into the house and found her in the kitchen. We noticed, I would say, there was some blood scattered around the kitchen. And then when I got into the details on how this happened, and what happened was, I guess she was doing something in the kitchen, and the pump that she has was on her waist, but it was plugged into her port that's on her left anterior chest. And when she was doing something in the kitchen, it became dislodged. When it became dislodged, there was a certain amount of blood. There wasn't any bleeding on the initial exam, like she had gotten that controlled and everything. Nothing was pulled out. But their major concern was, we need to get this pump started, and we need to do this now. Now, when I started getting to the weeds, it's like, well, what is this medication? What is it for? And it was a velocity pump, and that's wasn't familiar with the medication on scene specifically, but just understanding what we know from a medication point of view is that there's a therapeutic index that some people have to maintain. We compared this pressures to get that level to get the effect of what we need. Now with pulmonary hypertension, we know there's a little bit higher level of pucker factor because we need that therapeutic index to maintain. How long has she been off it? What are we going to do if we can't get it started? So we just started kind of going back into what are we going to do for this pump? The other concern that developed as we were getting our line, this is a Velatri medication, which is something that's not in our Bernalillo County protocols. So I knew we needed to get this pump reestablished and restarted. So we just elected to go from whatever settings that they had on our previously, restarted it that way. We began getting that pumped, restarted, and reprimed as someone was calling an MSET to let them know what we had going on. And then spoke with one of our EMS fellows that's moved on since. But he was real pivotal on give us the information. Okay, this is what you're doing. This is what the medication, yes, you need to get it restarted. Just confirming all the things that I was thinking, which was huge because we can have all the experience in the world, but when we start erring on the side of the patient and moving in the area that we're just unfamiliar with, having that to fall back on was, for me, critical because now I'm like, okay, cool, we're making the right calls. So It was a great support for that. But we're successful in getting it started.
Excellent.
That's what it boiled down to.
Yeah, speaking to the unfamiliarity, it's not a condition that we come upon regularly. We don't have a specific guideline any longer that talks about how to treat pulmonary hypertension. So taking a step back, Doc, talk to us, give us an overview of pulmonary hypertension and what we should expect.
Yeah. So pulmonary hypertension usually has to deal with lungs that are very stiff or fibrotic or hard to expand with oxygenation, and it puts a lot of pressure on the right side of the heart. So functionally, pulmonary fibrosis or pulmonary hypertension can lead to right-sided heart failure. And sometimes the right side of the heart just isn't strong enough to push that blood into the lungs where it needs to go to get oxygen. So these patients can be very sick. And towards the end of this disease process, when it's a little bit too much for the heart to handle to maintain oxygenation, these patients are placed on different pumps. It's a continuous infusion. Velitri is probably the most common right now. The previous one used to be Flolan, but Velitri is a little more effective. And what this does is it helps dilate pulmonary vasculature so the right side of the heart doesn't have to work as hard, and it can improve oxygenation and blood delivery to the lungs. It actually is a derivative of Viagra. It works the same. And so just like Viagra, which we learn about in school, you can get the hypotension or the flushing that can come with that. But this is specifically directed for the lungs to help improve oxygenation. And when you see folks with these pumps, you need to realize that they are absolutely dependent on this drug. I think it has a half-life of maybe 5 minutes, and it must be a continuous infusion. Otherwise, you basically, if that's discontinued, you put them into instant right-sided heart failure, which can be a disastrous thing to try to handle without it.
So the main key for us is if we encounter these pumps, just like Cap did, was he recognized the pump, knew that it had to be flowing. You talked through the short half-life on that medication. Can you just talk through how that improves that pulmonary pressure?
Yeah, so it basically just relaxes some of the vasculature in the lungs to help increase blood flow, and is really very effective. But patients pretty quickly become dependent on that for their oxygenation.
That's great. So just patient presentation, how did she present to you? Was she alert? Did you say you noticed some of the blood on the floor, but how did she present in your assessment?
For us, she presented that she was very calm. She wasn't really up in arms. Her family was probably a little bit more excited than she was, which is, to me, an interesting dynamic. Simply stated, she just was real calm. She was probably the best director on what needed to happen. There was another family member there. I think it was one of her daughters that, while the patient knew what needed to happen, the daughter was more of this is how we're going to do what we're going to do. And I guess she had had this experience before in a different area, and she knew what needed to be done, which was a great source of information.
That's great. And it looks like vitals were initially stable, 85 for a heart rate, looks like 157 over 77 for pressure setting, 93%, and good respiratory rate, alert and oriented, kind of the way that you described. And you mentioned earlier how you identified early that we don't have the ability to access those central lines, so the key was getting that line flowing again. So you touched on it a little bit, but talk through what you actually did in order to get that reestablished.
So the pump itself was just a small black square box, and there's a couple different buttons that were on it. From what I recall, there's one on and off button, there's a menu button, and then there's I don't remember what the third button was, and that might have been just 2 buttons because this call happened quite a bit of time ago. But the other part was on the bag was the written orders. So just that's going to tell you what the flow rate should be, how long it's supposed to flow for, that sort of thing. So our concern was there enough in the bag to make sure that we could get a prime and then reestablish flow. I believe we changed out the bag, got her a new bag to make sure that we had everything that we needed. Simply hit the on and off button. There's a little prompt on the menu button to say prime, so we pushed that, got the prime. Once we got the prime all the way through to the edge of the catheter, by that time the peripheral line was started, and we just simply plugged right in.
Fantastic. And these are typically, you can ask the family, obviously, what you guys did, because they're usually the experts on it, or if you have a nurse on site, which actually they did, because Captain Irizarry is one of the only members, if not the only member in our department who actually has a paramedic license and an RN license as well. So it was great. You talked about the MSEP kind of walking you through that, and as you got it reestablished, did he offer any alternatives to say if you can't get it reestablished on what to do next?
I don't recall him giving those directives. I will say that when we walk into those situations, I try to default to that because essentially like, what if we can't get this happening? What if we can't get the pump to restart? What if we can't? What if we can't? It's really kind of the summation of what I think when we walk into these calls. And my thought process in that was like, if this doesn't happen and we can't get this real started, the simple knee-jerk reaction, or maybe not the knee-jerk, but just we're going to support BLS with oxygenation and everything. But where are we in relation to the closest hospital that can handle that? Being out at 18s and some of the other districts around the city, I think you got to think in those terms. So this way you can try to be proactive. We weren't too far from Russ Medical Center, so I remember thinking, okay, you got a little time. If this doesn't go the way you need it to go, you need to just pull the trigger and get en route to the hospital. Another thing that I recall, like ambulance, AS was definitely on the spot with us, so we had an ambulance on scene fairly quickly. But oftentimes I think crews find themselves into a situation where are we critical status? Are we level 0? How far out are they? Because a lot of times when we ask those ETA questions, or when I ask those ETA questions, I'm asking so I can make a decision. And oftentimes it's going to be, am I going to transport or not, or do I have time to even think in those terms? So that's how it went down for me on this particular issue.
But you were successful in this case. You were able to get it reestablished, flowing,
Yes.
and then she did all accept a transport to the hospital, I assume?
Yes, sir. Yes, sir. We got her there. We tended the patient on the way there. She didn't develop any other symptoms, so that amount of time that she was off that medication, fortunately, didn't seem to present to us. But it seemed to work out in our favor this time.
In Russ Medical, you talked about being the closest. Is that where you guys ended up going, just the closest destination?
Yes, sir.
Okay.
Yes, sir.
And Doc, in terms of so there specific instructions on the back of the medication, like Cap described, essentially those are standing orders, but it is important for us to also make contact with MSEP to ensure that we have approval to follow those standing orders that are written for the patient. Is that how you see it?
Absolutely. He did a couple of really good things here. Calling IMSEP, it's always nice to be able to phone a friend, especially if you're a little bit out of your comfort zone or dealing with a medication that you don't quite understand, and get some orders for that. If the orders hadn't been if you hadn't been as comfortable working the pump and following the prompts, the IMSEP could have helped go through that. This is a special subset of a patient population that I kind of equate to LVADs. These are technologically dependent patients that have to have that technology in order to keep them alive. And so when you reach that kind of potential acuity and unfamiliarity too, because they're pretty rare in the city, but they are out there, it's nice to have an IMSEP to fall back on and ask for some advice on how to handle it and kind of bridge the gap until they can get to definitive care. And then the peripheral IV here was an excellent idea to keep it going. And I would also, if you can't get the peripheral IV, consider IO. If she's amenable to that, that's always tough on an awake patient, but it's one other thing. Or just go the BLS route, like you said, and just hurry and get to somewhere that can get it reestablished.
And as a last resort option, which I'm sure the doc would have talked you through too, is if we did have a pump on scene, whether that be from one of our pumps that the 7/8 carry or Albuquerque ambulance, as long as we have the medication and we could recreate those settings, would that be appropriate as well?
That's an excellent question. I think in this instance, if this is where the family and maybe like a nurse, if they're available on site, that knows the settings and is very familiar with the medication, if we have that detail of how it's to be administered, I don't see why we couldn't use our pump if the patient's pump is broken.
Excellent. Well, thankfully for this patient, the situation she had, a paramedic and a nurse on scene who was able to troubleshoot it, got the doc at the line to kind of walk us through that, got her to her definitive care, and maintain that course of treatment. So you guys did a fantastic job on this call, and we really wanted to highlight that because this is an anomaly. It's not a call that we see every day, and it was handled to perfection. So I really appreciated you coming out and talking to us about it.
Thank you. Thank you.
All right.
Thank you for having me.
Well, great. Well, I appreciate the time. Like I said, if we have any other case studies that anybody's interested in, if you have a cool call, reach out to us. We have a SharePoint tab, or you can reach out to your assigned 7/8. Until then, we'll see you with the next case study. Thanks.